guys have your study guides? Let's do this. So, what I'm gonna cover 10 topics, guys, on the study guide. So make sure that if you guys have something in particular you want me to cover, let me know. I'm only gonna cover 10. How many of us are almost done, or at least done, or done with the HIV?
Almost.
Okay. Almost? All right. Let's talk about this comprehensive review sheet. Did it help out? Is it helping out? Okay, good. Any questions on the patient's Bill of Rights? No? Okay. Folks, what's the difference between your local and your general anesthesia?
Local is at the state,
Yeah, let me explain something real quick so you guys can understand how this works. When you give a local anesthetic, think of these aren't bones, by the way, folks. This is these are, let's call these receptors. These are very microscopic. They're on our tissue. So when we have pain, whatever happens with the, let's say we have the,
Thank you.
bless you. Let's say this is the top of the skin, right, guys? Folks, let's say this is the top of the skin. Let's say these are the cells that interpret pain or sensation. So if you poke somebody, it sends an electrical impulse, okay, remember afferent, efferent? Okay, to the passageway that sends that message to the brain, and the brain says, oh, it's pain. So anyway, when you give a local anesthetic, think of this as the nerve, okay? And there's a little gap in here, okay? The little gap, because look, there's gaps everywhere in the nervous system, but you have neurotransmitters, or these chemicals, that send the information from one nerve to the next. So when you stab somebody, let's say, or you cut yourself on the skin, it sends a message to the nerve, and then it sends it up to the brain, and then that's how we get the manifestation of pain, like ow. Same thing with burning yourselves, or something that feels good, whatever the case is, right? When you give a local anesthetic, we're numbing up this location right here. The messages that have to get to this particular area are being blocked. So the manifestation would be local numbness or local deficits in sensation. Does that make sense? Meaning only in this particular area. That's local anesthesia. However, when we give, this is a brain, by the way. When we give general anesthesia, what's being blocked? The brain or the central nervous system. So this has a systemic effect. Okay, guys? And on the other hand, when we have local anesthetic, we only have a deficit in sensation, meaning we just have numbingness. But when we do CNS depression, or the depression of the central nervous system, okay, we have no feeling, but along with no feeling, what else is decreased? Respirations, heart rate, blood pressure, okay, even mental function. Okay, so all these elements are being depressed. Sometimes if you get enough anesthesia, what does the patient have? What do we have to do for the patient while they're in general anesthesia? Ventilate them. We have to ventilate them. Sometimes we have to give certain. Now remember, guys, the heart pumps on its own, right? The myocardial cells, the heart cells, they want to pump on their own. Remember, so we don't have to actually necessarily do that for them, but we do have to provide respirations. So when the patient's post-op, okay, and if we're breathing for them, who breathes better for the patient? Do we do or do they do?
They do.
They do. So what do we have to monitor the patient after any type of general anesthesia?
Respiratory distress.
Okay, respiratory distress. What else? Fluid in the lung. Okay, what else?
Depression.
Okay, not depression. If somebody's been in surgery for 6 hours, guys, the machine's been breathing for them.
Know that they have their respiratory response.
Or circulation because they don't get.
Okay, circulation, all right, what else? What's gonna happen to the respiratory system if we don't, what do we usually counsel the patients in doing? For prevention of
Deep breathing.
coughing and deep breathing and center spirometry, the little machine that you inhale. Okay, why are we doing that?
To make sure.
To prevent atelectasis. Okay, to prevent atelectasis. That's the whole purpose of term 2, folks, by the way.
Just prevent atelectasis.
Well, yeah, pretty much. To make, because post-op, every system you guys cover from now on, that's gonna come back. Venous stasis, pulmonary stasis, potential atelectasis. So it's important that you guys remember those key elements. I don't want you guys to go to term 2 and forget about this, term 3 and forget about this stuff, okay? It's really important. Now, I talked a little bit about deep breathing and coughing. It prevents atelectasis. When is it contraindicated?
Intracranial pressure.
Surgery on
surgery on the
There you
eyes,
go. So the only time when coughing is going to be contraindicated post-op, guys, is any patient that's had some type of any surgery in the head, whether it's eye or the ear or the brain or the spinal column. You don't want to have them cough because it increases that ICP,
Pressure.
the intracranial pressure. How do we know if like let's say they had a craniotomy? They opened up the head, and how do we know if the cerebrospinal fluid is leaking?
Out of the ear.
Okay, out of the ear. How do we know?
If it's sweet, you take a glucose test.
If it's sweet, yeah.
Taste that.
It tastes. A patient has just had some type of surgery, right, guys? And then you notice that the patient's got a lot of drainage in their nose. Okay, the way you know if it's cerebrospinal fluid is that you test it for glucose. Okay, there's a special little test kit for that as well, by the way. All right, good. Well, that's the difference between local and general anesthesia. Let's see. What's evisceration?
When the organ comes out,
Okay.
intestine from a surgical
That's right.
incision.
And what causes evisceration? What happens before that?
Dehiscence.
Dehiscence or dehiscence.
There you go.
Dehiscence, the opening of a surgical wound. Okay, good. How do we treat that? What are the, first of all, I'm sorry, guys, listen. What are the common goals if your intestines come out? What are the common goals? Keep it moist.
No infection.
Not compromised.
Not compromising infection. Okay, so sterile, moist, what else?
Keep it covered.
And you keep it covered. So practically that's pretty much it, okay? Good. What?
You don't.
You do not put it back in. Why not?
That's the doctor's job.
That's the doctor's job, yeah, let them get paid for it. Yeah, because we could cause more damage because we could be introducing now more bacteria inside the peritoneal cavity, that's right.
Don't cough.
Okay. If a patient's about to undergo surgery, folks, what type of medications do you want to have them stop taking about a week before? Any type of blood thinners, NSAIDs, aspirin, okay, anything that might make the patient bleed out a little bit. If the patient's on Coumadin therapy, what do you assess as the lab test? PT-INR for Coumadin, the PT-INR. If you give too much Coumadin, what medication do you give to reverse the effects?
Vitamin K.
Vitamin K. If your patient's taking heparin, what lab test do we look at? PTT. Okay. What medication do we give if we give too much heparin to reverse the effects?
It's for
heparin.
that other one.
What letter does it have in it? A P. No one remembers? Protamine, yeah? No, protamine sulfate. Okay, guys, protamine sulfate.
Okay.
Listen, guys, the whole Coumadin, vitamin K, or heparin, protamine sulfate will come up on the NCLEX. It will come up on the NCLEX, guys. It'll come out on your exit exams. You guys know? Shh. You guys know you can't take your NCLEX if you don't pass your exit exams?
Yes.
You guys are familiar with that, right?
Yes.
Okay, so just please know that if you guys don't, you guys are in term 4, and you guys don't remember these basic elements, guys, you won't be able to take the NCLEX. Okay, and I know people right now that their class graduated already. They've been done for the past 2 months, and they still haven't passed the exit exam.
Wow.
Don't be that student. What I'm telling you guys right now is it's very basic stuff, But this will help you answer any type of questions. I'm kind of going over everything that we talked about throughout the term. Okay, throughout the entire term. All right, looking back at these lab tests, and in term 3 and term 4, you'll talk more about lab tests, in particular in term 3. So for heparin, we look at the PTT, right? If your PTT is elevated, what does that mean? Your blood is thinner, so it's taking longer for you to clot. What are you at risk for?
Bleeding hemorrhage.
If it's low, what does that mean?
Clotting too fast, like thrombus.
You're clotting too fast, thrombus. You guys have to understand that concept, okay? You guys know what a therapeutic level means?
Where it's working.
Not so much homeostasis, because if somebody
It's working good.
for this particular
Where you're
patient,
supposed to be at.
yeah, it's where you're supposed to be at. So if I have a DVT, a deep vein thrombosis, right? The whole thing that we're worried about is for that clot to be dislodged and it becoming an embolism, right? An emboli, traveling somewhere and getting caught in my lungs and my brain, right? So we keep them on Coumadin or heparin, and we maintain their PTT or the PTINR relatively high in a therapeutic level. So for us, okay, we have that level that's therapeutic for healthy individuals, right? But for that patient that's sick, theirs is a little bit higher. That's considered a therapeutic level. What's a therapeutic level for any patient that's on PTINR or PTT? How many times above the control?
2.
Okay,
2.5.
1.5 to 2.5, or 2. Okay, or 2. So usually 1.5 to 2.5 times the control. So I'll give you an example. If I clot in 30 seconds, if my PTT, let's say it's 30 seconds, okay, is 50 seconds okay?
No.
Yes.
Oh.
Yes,
Yeah.
because it's.
No, 1.5 to 2.5 times more.
Yeah.
Okay, so this is okay. How about this?
Yes.
Yes.
It's still okay. How about this?
But wait,
No.
That's too high. Okay? It's got to be 2.5 to 3.5 to 1.5 to 2.5 times greater than the control.
wouldn't the 70 be like 4 times greater than the 30 seconds? So would that be 200?
So we have 30 is 1, right?
Mhm.
Another 30 is
60.
60. That's 2 times.
Oh, okay.
So you see what now? This barely meets it's a little under 2.5 times. So anyway, you guys just have to really. We won't give you a question that's right on the border, like for like 5 points off or something like that. But just understand these concepts. When you guys get to term 3, the first system you guys covered is cardio. Okay, it's very extensive, guys. It's really extensive, and you'll be covering all these lab values because you'll get to like peripheral artery diseases and
So-
clotting. Yes.
So we're gonna go through all the systems again, but labs.
No, you guys are gonna go through different systems now. Systems that involve more lab tests. Remember when we're doing like musculoskeletal? Did we really talk about labs?
It's more like introduction or kind of like.
Well, no, that's pretty much it. When we talk about musculoskeletal, guys, all we're talking about is like fractures and
Right.
muscle disorders. So the concept that you guys have to remember is this: if a patient has a hip fracture, what position do you want to keep the leg on? Abducted or adducted?
Away.
Abducted.
Anyway.
You gotta, not so much, but
Oh, sorry.
you gotta keep them abducted. You guys remember that? So those are basic principles that you guys have to adhere to when it comes to musculoskeletal. All right. How do you prevent venous stasis, guys?
Walking.
Ambulation. If a patient's post-op, one of the most basic things that we can do that's non-medicated is start ambulation as fast as we can, depending on what the patient's at, right? What type of surgical procedure?
Like compression stocking.
Or a compression stocking, okay?
To prevent blood clots.
That's right, or TED hose. Okay, the TED hose are the stockings. We also have the, what are the ones that are inflate and deflate?
Or the compression.
They're called something else. I forget what they're called. But you have these other ones, guys, that look like little booties almost, and they compress your calves and they relax. They compress. So it's working as a circulation system. It's promoting venous return. If you have a DVT, guys, on your right calf, what do you not do to that DVT? Massage it. Okay, good. You don't press on it, yeah. All right. When do we need an informed consent?
Surgery.
What type of surgery?
Invasive.
Okay, yeah, invasive guys. Anytime we're going inside the body, even if it's a shot of contrast dye for some type of imaging, like an angiogram, we need that. And you guys will discuss angiograms in terms of, we haven't talked about that just yet. All right?
Explaining the form.
What was that?
We don't explain it to them, or do we?
The doctor's in charge of explaining all procedures. If they have questions, we can answer a couple questions, but when it comes to the risks and the potential complications, that's the doctor's role. Okay? What do we do as nurses?
Just have them sign.
We get signature, and if they have any more questions, we can answer them, but it's specific to the surgery or anything like that, you gotta have them ask the doctor.
Even we can see the images.
Yes, that's right. All right, what's Preop Bed Preparation? I said I was only gonna go over 10 of them, I'm probably gonna go over all. Preop Bed Preparation.
About the shaving, getting ready.
And getting all their belongings.
So before surgery, how does the bed look? Open, high or low level?
Hi.
High, because we're anticipating a transfer from one bed to the other. Does that make
Oh,
sense?
yeah, okay.
Now, if I just worked on my patient, right, we just transferred the patient to the bed, and we hooked them up to everything, and I gave them some Valium because we're pre-medicating the patient. I'm about to leave. What things do I make sure are?
Bed's low, wheels are
The
locked.
bed's low, wheels are locked, adequate side loads are up, and the coli is within reach. All those things, guys, that it's supposed to be like second nature from now on. If I have a leg amputation, and if I tell you I still feel pain on my toe, why is that happening? So what is phantom pain, by the way?
So fake pain.
It's a what?
Fake pain.
Fake pain? It's real.
Brain still.
Yeah, the brain still registers that there's something there. You have to be able to
Is it
explain
because the
it.
nerves are still sending an impulse?
The nerve is still sending an impulse, and when there's nothing there, it manifests itself in pain. But if you guys Google phantom pain, there's real no clear-cut definition as to what's happening with the patient. It's what we think. This is what I read. What's carpal tunnel syndrome?
Kind of inflamed.
Which nerve?
The median.
Median nerve. Okay. What things can you not do?
These
You
two
can't
fingers
grab.
become
In particular, these three right here, or these three, but sometimes it's only these two. You can't flex them. Okay, you can't flex them. How do you develop carpal tunnel syndrome?
typing.
Repetitive, little small movements, right? Okay, good. What, playing what? What's Candy Crush? I know what it is. Alright, what's a sprain? Hyperextending, so you pull something, okay? You pull a ligament. What's a strain? Usually there's microscopic tears. So think of sprain with a P, you pull it. So you pull it, it hurts. If you strain it with a T for tear. Okay? How do you, what was that?
No, I like that one.
Oh yeah, I just came up with that last night. But anyway, and that's true, I really did. My friend was really, and he started doing push-ups, and he's like, I think I broke my thumb. I'm like, no, you sprained it, you didn't strain it, so you're okay. Anyway, how do you take care of a sprain or a strain? How do you care for it? Rice. The right side, that's right. You rest, you ice, you compress, and you elevate. Why do you rest it?
So it can
So
heal.
stop the injury.
Stop the injury so it can heal. Why do you ice it?
To
To constrict blood vessels, limit swelling. Why do you compress it? For the same thing. Why do you elevate? For the same thing. To increase venous return, that's right. When would you put heat?
after.
After. Hours after. Okay, initial 12, 24 hours, ice. Do you leave it just on the bare skin?
No.
You have to have a protective barrier, right? Okay, good. You do 20 minutes on, 20 minutes off, 20 minutes on, 20 minutes off. Mind you, it can be less than 20 minutes. Some people have a lower tolerance for pain, particularly women, but you know, it's usually men. It's usually men. All right, we talked about embolisms, anticoagulant therapy, rationale. We talked about that. Care of a patient with hip replacement. We talked about that. Compartment syndrome. What's compartment syndrome?
When a cast, like, it becomes swollen inside the cast and destroyed it.
Not necessarily in the cast, but it does happen in the cast. It can be because of some type of crush injury, right? And everything swells up, and it's swollen so bad that the circulation stops. How do we take care of it?
By cutting open.
What's it called?
Flashlight? Like
Fasciotomy.
fasciotomy, there we
Good.
go.
You remember, guys. As the NCLEX is multiple choice questions, so to kind of have an idea of what it's called, you'll be able to identify it. So that's good. And mind you, you're in second term. By the time you guys get to fourth term, you'll say like compartment. You get closer and closer. Okay, so it's okay if you guys don't know the word exactly just yet. When we assess for compartment syndrome, what type of clinical manifestations are we going to observe?
Numbness,
Numbness.
cyanosis, and the
Cyanosis, swelling, decreased capillary, all the signs and symptoms, guys, of decreased perfusion or inadequate blood perfusion. Okay, let's see. When we're assessing the neurovascular assessment, we're assessing not only cap refill but also sensation. Okay, what if we're doing, if you're assessing somebody's blood pressure or vital signs, let's say, somebody's vital signs, what system are you assessing?
Blood pressure is going to be.
Hold on, listen to what I'm asking you. For those of you who can answer that, if you're assessing vital signs, what system are you assessing? The cardiovascular system. Oh, the circulatory system, yes, it's the same. Yeah, the cardiovascular system, the circulatory system. All right, good. What part of the brain controls the temperature? Okay. How long should a capillary refill be?
3
3 seconds or less. If you have a patient that's going into shock, how do you care?
Give them O2.
Give them O2. Good. What else?
Trendelenburg.
Trendelenburg position. Where you elevate the extremities. Keep them warm. Good. Good. Okay. What type of foods are high in calcium?
Milk,
Dairy
products.
Dairy products.
Broccoli.
Good. Broccoli is high in calcium. Yogurt. Okay, but broccoli. All right. Why do we need calcium?
For bones.
For the minerals.
Well, yeah, you need calcium for vitamin D to grab onto calcium and to throw it in the bone. Guys, when there's, you guys probably think that calcium just goes straight into the bones, right?
No.
No,
Okay, good.
It stays in the blood.
It sometimes stays in the blood. It has to stay give that therapeutic level, right? What ends up happening is when you have a certain amount of calcium, it stimulates the osteocytes or the cells in the bone to break down calcium, and then it breaks down calcium and then it releases it into the bloodstream. And then when you break when the osteocytes, the osteoclast, it breaks them down and the osteoblasts rebuild. They utilize some of that. So that's what ends up happening. FYI. Let's see. Talk about GI now.
You're not gonna do diverticulitis.
That's GI.
Oh.
What's the difference between diverticulosis and diverticulitis?
Diverticulosis is when you actually have fecal matter in it. Itis is just inflammation.
Okay, yeah. That's good stuff. That's good stuff.
Are those, I have a question. So those are hernias on the colon?
Wait, they're herniated pouches.
Pouches in the.
Meaning the tissue has gotten weak and it bulged out.
Okay.
That's what it's talking about. It's going into the space, another space that's not, it's like, this is the lining of a regular intestine, and when they're herniated, it just means now they're pouched out, they're out somewhere else where it's not supposed to be. So. All right, folks, so let's talk about the GI real quick. Where does GI system begin?
Mouth.
The mouth. Okay, so it comes down the esophagus. Okay, let's get to the large intestine. Oops, that's kind of ugly. But anyway, so folks, real quick. You guys have a question? Okay. When it comes to the diverticulosis and diverticulitis, osis is when you have a pouch, but there's nothing in it. Okay? Itis is when there's fecal matter inside and now it's inflamed. It's infected. It's gonna hurt now. Usually, where do you manifest the pain?
Send the call.
The colon. Usually the left lower quadrant. Usually the left lower quadrant, because you have more of them right here. And that's where the fecal matter actually builds up a little bit. So as soon as there's any distension, you feel it more. While it's traveling through here, even though you have diverticuli here, it just keeps passing on, right? So right here, usually it backs up if you haven't had a bowel movement. So that's why you feel it in the left lower quadrant. Does that make sense? Okay. What's a potential complication for diverticulitis?
It can rupture and cause sepsis.
What do you develop?
Oh no, that peritonitis.
Peritonitis, yeah, peritonitis. You develop sepsis when it goes inside your bloodstream. All right.
In those conditions, you want to give them low protein, right? And more vegetables? Because I know that you don't want anything that's going to create any kind of gas.
Yeah, but the problem is, so what type of elements can we include that won't produce gas?
Just
It's spinach.
Mineral oils. Remember mineral oils. But yeah, you do want to give an adequate amount of
brassicas or whatever.
that's right. What's it called?
Gassy food.
Come on, guys. Like you're responsible for memorizing
Garbanzo
these, right?
beans, kidney beans, pork beans.
Yeah. What's it called though? What's a bulk that increases the bulk?
Fiber.
Fiber. There you go. You want to give them fiber. What do you not want to give them?
Gassy food.
Gassy fiber.
Gassy's true, but not so much gassy right now. What's gonna accumulate inside those pouches?
Meat,
Seeds, so foods that have high residual. High residual, okay, high residual. All right, if somebody has a gastrectomy, they don't have any intrinsic fiber being released, so they can't break down B12. Okay, you guys remember that, right? You develop pernicious anemia. Okay, you guys remember that?
Yeah.
All right, so what food elements contain B12? Meat. So people who are vegans are going to be at risk for B12 deficiencies, right?
Yes.
And if you need B12, if you have a gastrectomy or if you're a vegetarian, you want to make sure that you include it in your diet. If you're a vegan or if your stomach's not working, then you want to get monthly shots, right? What's the main difference between ulcerative colitis and Crohn's disease? Ulcerative colitis has blood and up to 20 BMs a day. Crohn's disease has mucus, okay, and about 4 to 5 BMs a day. Okay, they're both painful. This is what you don't want to cause. This is when you want to give low fiber. Low fiber.
On my last test, I killed my patient.
If you have a patient that has a lot of diarrhea, what's the biggest concern? Dehydration. Okay, how do we make sure that the patient stays hydrated? Give IV fluids, or you give oral intake fluids. Okay, good. You guys remember everything about ileostomies, right? Okay, good. Yeah. Appendicitis. What's the area right here? What's it called? McBurney's point. McBurney's point. What's the type of pain that it has? You have rebound tenderness. That's right. Usually lower right quadrant, right?
Yeah.
What can happen if it ruptures? Peritonitis. You can become septic. You can die. What do you not want to give these patients when they have appendicitis?
Too much painkillers?
Morphine. You don't want to give them too much. No, you're right though. You don't want to give them morphine or any other type of analgesics because it'll mask the pain if it ruptures. Right.
And even heart
That's right.
company.
That's right. Let's see. How do we flush an NG tube? With normal saline. Peristalsis, you guys know that. Know what peritonitis is. Peptic ulcers. What's H. pylori?
The cause
The cause of peptic ulcers. Yeah, it's the most common agent. So if somebody has that particular bacteria, what do you guys have a question? What type of agent do we use to take care of the H. pylori? It's antibiotics. Okay, good. Liver panels. What type of liver? We've done liver panels. Yeah, we did. Yeah, we did accessory muscle organs for the GI, which are elevated during some type of liver issue. AST, ALT, alkaline phosphatase. Good. The BUN, the blood urea nitrogen. Good. more for renal, but it's okay. What's the difference, guys, between hepatitis and liver cirrhosis?
Liver cirrhosis is worse.
Liver cirrhosis is worse. That's essentially the main difference.
Like abuse, alcohol.
Yeah, that's right. So if somebody has liver cirrhosis, guys, it can lead to a decrease in breaking down of ammonia. What can that lead to?
Hepatic encephalopathy.
Encephalopathy, that's right. Hepatic encephalopathy, what can that lead to?
Brain damage.
Brain damage, coma. How do you know this patient might be having some increase in ammonia?
ALOC.
ALOC, that's a level of consciousness. What hepatitis do we usually get a vaccination for? Hepatitis B. A as well, but B as well. What's hysterexis?
Is that the tremor?
The hand flap, the hand tremor, yeah, that's right.
From high ammonia, right?
From high ammonia levels, that's correct. Let's see, let's skip pancreatitis. We want to read up on it. What medication do we give for a liver transplant? Cyclosporine. Cyclosporine, that's right. It's not on the test, but you should know. What can lead to cancer of the pancreas? Pancreatic cancer. Smoking, alcohol, trauma, yeah, that can too. Ingestions of food that are high in fat. What is phagocytosis? That's right, when a cell engulfs any bacteria. Okay, good. What's a Schilling's test? To diagnose pernicious anemia. Make sure you guys read up on Schilling's test. What are lymphocytes?
White blood cells.
Yes, specific white blood cells. What are they responsible for? Phagocytosis or the immune response. What is aplastic anemia?
That's one from the bone.
That's right. When the bone marrow is deficient, all cells are not being manufactured
The red
adequately.
marrow turns more to yellow.
Pardon? Yeah, the red marrow is decreased, the yellow marrow is increased. That's correct. What are thrombocytes?
Platelets.
Okay, what's the average quantity of
150 to 400.
150 to 400,000? That's right.
What was it?
150 to 400,000. What happens if you have thrombocytopenia? What's going to happen if you have thrombocytopenia?
Lack of
I know, that's what it is. So what-
Bleeding.
Bleeding. Okay, well. What are, please know what disseminated intravascular coagulation is, okay? DIC. What are leukocytes?
It's a white blood cell.
White blood cells. How many types of white blood cells do we have? 5. We have granulocytes and agranulocytes, right? We'll be talking more about that in terms of also. What do leukocytes do?
Fight.
Fight off infection. If they're high, what does it mean?
Infection.
If they're low,
Immune
immunocompromised. What's the average leukocyte count?
4,500 to 11,000.
Yeah, that's right. What is epistaxis? Bleeding from the nose. Good. You guys know how to take care of it?
Yeah, leaning
Yes,
forward.
yes.
Forward, pinch, for 1 minute?
The whole thing?
About 5, at least 5 minutes, yes. Like sometimes it could be 15 minutes. You remember COPD?
Yeah.
Chronic obstructive pulmonary disease? Okay. What are these patients going to complain of?
Heartburn.
Okay, they're also going to have that
Heavy marrow stem.
Barrel chest.
barrel chest,
Esophageal varices.
clubbing of the fingers, okay? Are they going to have hypercapnia or hypocapnia? Hypercapnia, that's right, because they're
Cor
tendency to,
pulmonale.
they'll develop cor pulmonale, that's right. If somebody has pulmonary edema, what are you gonna listen when you also take the lungs?
Can you repeat the question?
If somebody has pulmonary edema, when you auscultate the lungs, what are they gonna sound like? Okay, crackles, guys. Crackles. Yes, it's gonna sound watery, but crackles. Okay, what's a tonsillectomy? Why would we require a tonsillectomy?
Constant infection or
Constant infection, usually, I don't know, 3 or more, 5 or more a year, I forget how many. But what happens, what type of the system are you removing?
the immune system.
Lymphatic system, the immune system, you're right. All right, what's a thoracentesis?
It's taking out the germ
from your chest cavity. You guys know what a thoracotomy is?
No.
Alright, so look, if you guys ever see that word, I just say it because it might come up on, it will come up on the NCLEX. Thoracotomy. Whenever we do, whenever we have to do a surgical procedure, guys, inside the chest, we perform something called a thoracotomy. We make a slit in the chest. We can, off of this slit, we can perform several surgical procedures, such as a lobectomy, pneumonectomy, the slicing of the pericardial sac to get rid of pericarditis, of the fluid inside. But just know what a thoracotomy is. It's the first incision that we perform on a patient that's going to have some type of either lung or heart surgical procedure. All right. Let's see. What's angioedema?
It's spreading on the
Yeah, there's tissues actually. Somebody's hypersensitive to something. How do you avoid hypersensitivity? Yeah, you decrease or you desensitize them. But if they have like a hypersensitivity, you want to just decrease the exposure to that particular allergen. What's a test for HIV?
Burns or what's during blot?
For HIV? ELISA, how you want to say it? The ELISA. So the ELISA, how many tests do we need to confirm HIV? Three. After the HIV test has been confirmed, what distinguishes an individual from having HIV to going to AIDS?
CD4 count below 200.
CD4 count, specialized T cells.
Fevers, chills, night sweats.
That's right. So anything below 200. Okay, please remember that. HIV and pregnancy. You guys, a lot of you guys ask me questions about this stuff. So if a baby is born to an HIV positive mother, will the baby be HIV positive?
Maybe not.
They probably will be HIV positive. I'll tell you why. Because they have the mom's antibodies. Okay, meaning, but that doesn't mean that they themselves have HIV. Remember, their immune system is completely dependent on the mom when they're in gestation. Once they're born, remember that we talked about the surfactant, the lungs take over now, and the septum of the heart closes, which you guys haven't discussed yet with you in term 3. And it's like the body's getting ready to live on their own, right? So the immune system is barely getting adequately adjusted for life on its own. So if the baby comes up with a positive HIV, it's typically because it's the mom's antibodies. So we usually wait a while and then we perform the test. Okay. Let's see what else. What medication can we give to suppress to prolong the AIDS development on it?
Oh, that. Some
What is it? Come on, it's in your book.
It's like,
I mean, it's in your exam. Which medication is it? What is it?
AZT.
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 That medication that's on your exam, folks, it's called the AZT. I can't pronounce it either, so I'm gonna call it AZT. This is medication that we give to any infant. Okay, we can sometimes start the therapy before they're born. Sometimes give it to them within 4 hours from the time that they're born. If we don't know it, like we just found out that the mom had HIV, we give it to them. Now, this medication doesn't necessarily cure the baby or prevent it, but it prolongs how long it'll take for the baby to actually develop AIDS. So if and when they ever do develop it, it'll be way down the line. It's good for the body. So that's what the AZT is. And you'll talk about the reason why we give those 2 exams, guys, as take-homes, is because you guys go in depth in term 4 about all these concepts. That's why the take-homes. Anyway, what's the difference between HIV and AIDS?
HIV is a precursor to AIDS.
precursor. So HIV is a virus.
Yeah.
Magic Johnson, HIV.
Positive.
Yeah, positive. Who's got AIDS?
Easy.
Easy E had AIDS. Is he alive? He's dead. Okay, good. Let's see. What's a PSA? Prostate specific antigen. So what does this mean? Okay, it could be an indication of cancer of the prostate gland. It could also mean the patient just had a digital rectal examination and the tissue is now releasing some of that prostate specific antigen. Remember the PSA, guys, is better as an indicator if it's getting better or worse, the cancer. Okay? What's a DRE?
Digital rectal exam.
Digital rectal examination. Yeah, Dr. Dre. You guys hear that? Apple's buying Dre Beats for $3.something billion?
What?
Huh? It's unimportant stuff, don't worry about it. As I talk about it during my study guide, right? What's cachexia? Ill health, being emaciated.
Yeah,
You guys remember the TNM staging?
Yes,
Cancer.
tumor, nodes, and
Nodes and metastasis. Good. What are some cancer warning signs? Cancer?
No, for bladder, the bladder.
Very generally speaking, guys. Loss of weight, the change in bowel habits,
Loss of appetite.
loss of appetite,
Depending on the type of cancer.
depending on the type of cancer. But if, what about like moles? What about moles?
They change
Changing
or
size.
They change the
Horses
size.
nest.
That's right. That's right. That's right. All right. What type of diets can reduce the likelihood of someone developing cancer?
high fiber, low fat.
High fiber, low fat, high antioxidants. I forgot to take my pill this morning. I got this pill that's it's like a bunch of antioxidants. I'm gonna take one a day. Not that I'll lose weight or anything, but at least I'll have the antioxidants. Because I snuck in a Superstar last night, like at 10 o'clock at night. It was horrible. It was really good. What's compazine, Reglan, Kitril?
It's for medication.
What was that? Make sure you guys,
That's the last one, right?
No, all of them, but make sure you know what they are. Make sure you know those medications. I talked about them before.
That's
Pardon?
those medications are antihistaminic.
Sometimes they're used for antihistamine, but they're antiemetics. Okay, so just make sure you look them up. External radiation, what does that mean?
From outside.
Outside. Talked about the ports. What do we not do with the ports?
Wash them.
Don't wash them off, no constrictive clothing. Avoid sunlight. What about internal ones?
Keeping something.
Limit the exposure to them. All right, good. How often does a woman? Actually, first of all, what's a breast? Breast self-exam, BSC. How do we perform it? Oh, I thought you were raising your hand. Hey, you raise your arms. Okay, you do it with the palm of your hand.
No.
Do it. Okay, in a circular motion. You start at the nipple, and you go around. Don't laugh, guys. After your menstrual cycle, usually because why not during your menstrual cycle? We always talk about.
Yeah, they're tender and you have,
What is that softer, softer? What is it?
You have, your glands are.
Look, this is why, guys. Listen to this. Listen. If you know why, then you don't have to worry about like when do we do it. Okay? You do it usually after your period because during your period, for females, don't tell me this, but usually what happens to your breasts? They become engorged.
Yeah.
Okay, they become very sensitive. Tender. So if a female does have a lump, you want to start assessing when it's going to hurt, and they're swollen as it is, you're not going to really feel it. So that's why you do it
Glands
after.
are swollen.
Yes.
Glands
Yeah,
are
the hormones are present, but I want you guys to understand it's swollen. That's why you don't go and do it during the menstrual period. Now, what if you have an irregular cycle?
Start grabbing.
You do it after
After your
Start what?
cycle.
Start grabbing.
It's like,
After your
What's wrong
cycle.
here?
you want to do it if you have an irregular period, guys. Ladies, do it on the same day every month. On the same, as long as it's on the same day every month, you should be fine. That's the theoretical recommendation. Okay. When do you do mammogram? Yeah, mammogram.
After 40?
Usually after 40. Sometimes it could be 35 and above. Okay. When do you start doing your breast self-exam?
After 20?
After your first period, usually. Yeah, usually in your 20s or teens. That's right.
But I have my boobs, so.
That's why I said as soon as you have your first period. Period.
Yeah.
Oh, sorry.
You have, yeah, here before we had boobs.
Yeah.
Right.
Right.
I'm so excited.
You guys have any questions? You guys have any questions? Look, come back, guys. I know you guys want to go home. I see you guys. Stop talking so much. And I know we're on the last stretch of the. I mean, we're pretty much done, guys. Come back. We're gonna watch a video. Okay. I haven't received the NLNs yet. I asked for them last week. I just haven't gotten them yet. As soon as we get them, we'll take them. If we don't take them today, we'll take them tomorrow. But we'll still have a field trip. I promise you guys. Yes. I don't have